Testing. I think, am I audible?
Yes, you are.
Thank you. Good evening, everybody. Welcome to the weekly KOA webinar event. My name is Dr. Asif Admani, and I want to introduce today to you Dr. Edward Sang, a good friend and colleague of mine. He works at Kikuyu Hospital, Kikuyu Orthopedic Rehabilitation Center, close to Nairobi. And he has a keen interest in orthopedic trauma as well as arthroplasty, revision arthroplasty, and arthroscopy. He is going to present today to us something on tibial fractures. Welcome, Dr. Sang.
Thank you very much, Dr. Abay. I hope I'm audible. I'm using the internet for my phone, sorry. Today we're going to talk about tibial fractures. So today we're going to talk about tibial fractures. I'm sure most of you have done these surgeries. In my experience, there are some shaft fractures that I've done in 17 minutes, others are done in 3 hours. But as a good surgeon, you always look back and see what you can improve, what you can make better, or or if you suffered in theater, what you can do to make life easier next time. I'm sure in my practice, almost 80% of my income comes from trauma. Then from the trauma, about 40% is from tibia trauma. So it's you may look at it as something simple, but it's not really that simple, because if you don't do it right, then you're going to lose clients. And if you do it right, then you're going to build your name through the tibia. So I won't bore you with so much of the literature. I'll just discuss a bit of issues pertaining to the tibia fractures. Then after that, I'll share some radiographs. Then I'll open the floor for any questions or discussions. So as we all know, most common long bone fractures, especially these are boda bodas, almost 25% are compound, but actually there's no local study that has delved into this to see what percent, but a big chunk of them are normally compound. They can either be low energy or high energy. Low energy are normally sporting injuries, twisting injuries, football, rugby, falls from heights, or high energy in road traffic accidents, falls, blunt trauma, or gunshot wounds. The low energy ones are normally torsional fractures. They're normally of simple pattern with fractures either on the tibia or the fibula, but at different levels because of the forces involved. High energy one have an increased incidence of neurovascular injury, normally from road traffic accident. And there's normally a high suspicion of, or most of them could be associated with compartment syndrome. So classifications, there are normally 3 major classifications. One that classifies them according to location, proximal, middle, and distal 1/3. Or the fracture pattern, either transverse, oblique, spiral, comminuted, or segmental. Then there's the common AO classification, where 4 is the bone, 2 is the level where it is, then ABC. So radiographic evaluation, we always fight with the radiologists because they don't normally give us the required views. Normally you'll want full-length AP and lateral views with the joint above and joint below, but most of the time we don't get these views. But hopefully with time we'll be getting these views. Then, especially the periarticular fractures or the proximal and distal 1/3, you want to have a CT scan so as to better study the fracture pattern. On radiographic evaluation, just something significant. There was this study that was published in the Journal of Trauma in 2011 by Panel et al. they had a standard CT protocol for all distal one-third fractures. And 43% of all those CT scans done had articular injuries. Only 45% of the total were detected in plain radiographs, and these radiographs were being interpreted by orthopedic traumatologists. So you can see the significance and the importance of having a CT scan evaluation, especially for the proximal or the distal third fractures. Patient evaluation, most likely from the history, mechanism of injury. Then 30% of them are normally associated with additional injuries, like floating knee, ligamentous injury, foot and ankle injury, and neurovascular injury, especially the high energy trauma. Two main management options: there's non-operative management, and this is very important because sometimes we push it to the limit because of financial and other issues, and we find that we are casting some fractures that will not heal well with casting. But I think if we always remember these 4 points, where 1 centimeter shortening, less than 1 centimeter shortening, less than 5 degrees of varus or valgus angulation, 10 degrees procavetum, less than 10 degrees of procavetum or recavetum, and less than 10 degrees of rotational malalignment. It's just 1, 5, 10, 10. If we always remember this, then it makes it easier for us to say, yes, this is conservative, this most likely needs surgical management. And the other patients that will not be candidates for surgery are either the non-ambulatory patients or patients who have conditions that may not allow them to undergo surgery. Non-operative, still on non-operative treatment, long leg cast, that's above the knee joint. Normally they advocate to the level of the gluteal fold. Then after 4 to 6 weeks, when the fracture starts getting sticky, we change to a functional brace or a patellar tendon bearing cast. We allow them to bear weight early. The average healing time is normally 3 to 6 months, but normally in about 3 months, most of these patients are healed. It won't be fair to talk about the operative treatment if we don't mention Sarmiento. Sarmiento did a study of 625 patients, although 30 of them were lost to follow-up. The average healing time was about 21.8 weeks, but it was longer in open or segmental fractures. 98.5% union rate, 80% healed with less than 5 degrees angulation. This just shows that it has non-operative management has a significant role in the management of these fractures. Operative management, probably an acceptable alignment, or after you cast a fracture and you find out that these angles are not matching and it's displaced, then you decide to operate. Severe soft tissue damage that cannot allow you to cast, high energy fractures, floating knee, ipsilateral fracture femur and fracture tibia, polytrauma patients where for ease of nursing and ambulation you want to fix all these fractures, or morbidly obese patients where it will be difficult for them or to nurse them with these fractures conservatively with a cast without falling into problems. Treatment options, operative. Nail, which is the workhorse. I'm sure each one of us does this in a week or in every week that goes by. Most of the time you'll have to nail a tibia or something. Then plates and plates, which could be locking plates, non-locking plates, stainless steel versus titanium plates, but these are discussions for another day. Then external fixators. But today we just want to discuss more, because we're discussing the shaft fracture, then we discuss more of the tibial nails. So there was a study that was done by Obremski and published in 2017 in the Journal of Orthopedic and Traumatology, where they were studying, there was less than 12 millimeters shortening and there was less than 10 degrees angulation. These are fractures that would have healed with conservative management, but they were nailed. So the ones that were nailed, it showed improved functional and clinical outcomes in 3 months compared to the other group. There was faster time to union, lower incidences of malunion. And at 6 months, there was no difference in outcome in terms of range of motion, return to work, and scores. So after 6 months, whether they were treated operatively or non-operatively, the outcome was more or less the same. Then there was a study of Hooper. This is a very old study from 1973, but still shows that more than 50%, there was this group that had more than 50% displacement or angulation. These are fractures that definitely would have not done well with conservative management. So these fractures were fixed with interlocking nails, and there was a faster time to union, lower rates of malunion or shortening. Probably they healed faster and better. Now nails. There are different types of nails in the market, but the commonest one are the second one, the tubular ones. The open section used to be there, but I don't think they're rarely in this market. The solid ones used to be there, but not anymore. The commonest that are around, most of us are using the tubular ones. Unless you're getting donations from outside, then you're getting this other type of nails. So interlocking nails. Two main entry points, the intrapatellar entry point, where an incision is made in the inferior border of the patella to the tibia tubercle with the knee hyperflex. There are two options. You can either split the tendon or go just to the parapatellar region. You can either go medial or lateral, as long as you aim your nail at the same level as the tibia tuberosity, in line with the tibia tuberosity. In the tibia tubercle, sorry. There's normally the semi-extended position, where this facilitates reduction of proximal or comminuted or segmental tibial shaft fracture. Because there are two ways. You can either go infrapatellar, where you really have to flex the knee to get your entry, or where you put a small bolster, but you go suprapatellar to get your entry. Now, initially, there was a proximal medial arthrotomy. There are guys who started by doing a proximal medial arthrotomy to allow lateral subluxation of the patella, because as you are rimming, especially if you have rigid rimmers, it's the patella that comes into your way. And when the patella comes into your way, it's normally quite difficult, especially if you're rimming if you're using the infrapatellar approach. But then Cole also published a paper in 2006 about the suprapatellar approach using the midline quadriceps insertion sites. Actually, there's no significant difference between the suprapatellar versus the infrapatellar entry point. Gelbke published a study in the Journal of Orthopedic Trauma in 2010, where he did a cadaveric study that measures the contact pressure on articular cartilage. Suprapatellar nailing had twice the mean contact pressure, but the pressure remained far below the threshold for chondrocyte apoptosis, meaning there was no difference, as in there was no damage that was caused. Chan did a prospective randomized study of 42 patients. 25 patients completed the follow-up. The suprapatellar group had an MRI pre and before and after the nail, and they also had an arthroscopy at 1 year. They only noted that 3 patients had change in patellofemoral articular cartilage post-nailing, and none had knee pains after a duration of 1 year. So there was no difference in pain, range of motion, or disability at 12 weeks. Lucia also published a study where he did a retrospective cohort study of 266 distal tibia fractures. I think it's the largest series to date that directly comparing the suprapatellar and the infrapatellar technique of insertion in the treatment. But this one was in the treatment of distal 1/3 tibia fractures. And they found that there was better reduction in the suprapatellar approach compared to the infrapatellar. Probably this is because of when you're doing the suprapatellar approach, the leg is normally straight, so you have easier fluoroscopy and easier reduction. Unlike the infrapatellar, where you really need to flex, and it's difficult to have those fluoroscopy shots. It's difficult to have those fluoroscopy shots, and also your assistant suffers a lot in trying to maintain the reduction. Now to the reduction techniques. There are many reduction techniques. If it's a simple fracture, then with fluoroscopy, you can use percutaneous clamps. You can use blocking screw, where the screws go to you can either use screws or K wires, 2.8 to 3.2 K wires can work, where the blocking screws or wires go to the concave side of the deformity. When you fix your nail, where the nail goes and causes the fracture to malalign, that is where your blocking screws normally go. So what you do, once you put your nail, you check with fluoroscopy, you mark where your nail is passing, take out the nail and put your blocking screw there. Then when you put back the nail, that screw will just force the nail to go into the right direction and you won't have malalignment of your segment. But this normally works just for the shaft fractures. You can use a femoral distractor or external fixators. And for the proximal fractures, especially if you're using the infrapatellar approach, where when you flex the knee, the proximal fragment goes into recurvator, and then you can use a unicortical plate just to hold as you do your removal. Commonest complication of interlocking nails are normally knee pain post intermedullary nailing. Most patients will have pain will have anterior knee pains, but normally, if a patient asks me if before they go to theater, if they'll have these knee pains, I normally group them into thirds. I say in the patients that I've done, a third of them will have severe knee pains, a third will have no pains at all, and a third will have pains that are neither here nor there. But from a study by Tonetta in 2011, he described that the pain gradually decreased as the fracture heals, and by the 20-week mark, there was minimal pain. After 20 weeks, there was no correlation between pain and union. And Cott-Brown in 1996 showed that removal of the implant, there was 27% resolution of symptoms, and 69% of the patient improved. But you see, the issue is if this pain and the fracture is healed, the worst thing to do is just be to remove the knee. Then to locking plates, normally these ones are normally for proximal 1/3 and distal 1/3 fractures. These are the interarticular fractures. They can be used in this mid-shaft fractures, but with the advent of nails, then most people avoid them. But in young children where they still have growth plates, then you want to avoid your nails going through the growth plates. But there are some techniques where you can avoid the growth plates as you also put your nails. There's a study by Valier who compared interlocking nails to plating of distal tibial fractures and found there was a higher rate of malunion with interlocking nails. That's a bit obvious because most of the time you have a very small fragment distally that tends always to go into valgus, but there was no difference in union rate or secondary surgery. So most of them united. The only problem was the issue of malunion. Lindvall in 2009 did a retrospective comparison of interlocking nail and plating of proximal tibial articular fractures. So he noted that with the percutaneous lock plate, there was a high incidence of implant removal, low incidence of procavatum deformity because you reduce your fracture. Because you reduce your fracture, and after reducing your fracture, you keep it maintained with the plate, so it's easier. And there was no difference in union rate between the ones that were nailed and the ones that used locking plate. Because I think the main issue here is just the technique. And if you know how to do it right, then I think it's comparable as long as the fracture is not intra-articular. So in recent systemic reviews that have been done, both techniques are effective in appropriately selected. Where they used to stabilize high energy open fractures. I used to stabilize. Sorry, just a minute. Sorry, you are at external settings. So external factors normally indicated for high energy open fractures, damage control orthopedics. Common complication in our setup is pin tract infection, because most of these external fixators are kept for too long. And then also the technique of how we are putting the pins, because most of the ones we have in the market are not self-tapping or self-drilling. So they cause a lot of necrosis, early loosening with the infection. External fixators, as we all know, they are agents of malunion, so we get delayed malunion from them. Have a higher rate of malunion if used effectively as compared to talokinase, although some fractures can be taken to union with external fixators, especially the ones with capabilities to compress, if they're simple fractures. So commonest complication with tibial sharp fractures, you have compartment syndrome. Commonly with diaphyseal fractures, both can occur in both open and closed fractures. And they're also common in athletes who get diaphyseal fractures. Non-union, common in tobacco smokers, diabetics, in segmental fractures or fractures that have bone loss, open fractures, and especially when you get infection, most of them could go into non-union. It is recommended that when you realize that there are issues with union, the best thing is normally to delay it for at least 6 months. And this has been shown to lower significantly the need for reoperation, because some of them heal. If you get to know what the problem is like, if like the fractures are still far apart, you dynamize, then most of these fractures, given enough time, will unite. Some of the treatment options include dynamization, rimmed exchange nailing, where you put a bigger nail than what was initially and allow them to bear weight early, or you do posterolateral bone grafting to stimulate bone healing, the posterolateral aspect, and with a good blood supply, then you get healing. Then the biggest issue with tibial fractures are infection. If you walk into any hospital and into the orthopedic ward, there are patients who have infected tibial fractures. For acute infection, it's not advisable to, for acute infection, it's not advisable to rush to remove the implant. Then what you could do is you debride, take advantage of vacuum dressing if you have vacuum dressing, and give antibiotics specific to the organism if you have lab support. And in a study done by Beckers in 2010, it showed that 75% went to union without chronic infection. Chronic infection was noted in open fractures, in smokers, and patients who had initial infection with Pseudomonas. The other thing I wanted to say about infection is that this compound tibial fractures, what we do in our setup is, if we get them early and they're relatively clean, we normally go ahead and fix them, especially the ones that don't have bone loss. We fix them and then we put vacuum dressing. And we found that most of them, although we don't have any published studies, that we found that almost 90% of them go into union and don't have any complications. So as we stabilize the fracture, then we sort out the soft tissue issues. I didn't manage to get the radiographs I wanted, but this is just an example of a simple fracture that was treated conservatively. This is a segmental fracture. It's if you've tried nailing such fractures, you'll find that if you use the infrapatellar, this piece will always be coming into the cavetum. The proximal piece will always be coming into perfect reduction. So there are two options here. If you have fluoroscopy, then you use the suprapatellar approach. The only thing with the suprapatellar approach is that you make sure your sleeve is always you make sure your sleeve. There's something wrong with the internet. I think it's certain. The only issue with the suprapatellar approach is you make sure that your sleeve is always bang on the tibia, because the commonest complication is rimming the trochlea. Because what happens is that you have your sleeve right inferior to the patella, just on the trochlea, and you're having your reamers going in and going out. And with that, it's easier because like you get your clamps, you hold the fracture together like the proximal fracture, you hold it, then you do your rimming, then you take in your nail, then you lock. That way it becomes up the knee joint. I clamped the proximal fracture, also clamped the distal fracture. There's normally a balance between biologic and also getting a good reduction. Because if you're not careful, this segment here, if you just go in rimming, you're going to take it down 360 and you're going to be vascularized completely. So what I normally prefer to do is a medial parapatellar atherectomy, just a small atherectomy to open the joint. But normally I try to, as much as possible, to stay extra-articular, just to allow the patella to flip to the lateral side, then clamp the fragments. After I've clamped the fragment, then I do my rimming, then fix my nail. Eventually, after you lock all your screws, you find that your fragments are stable. This was another segmental fracture, but this one we did with infrapatellar. But we opened it, it was a Gustilo one, so we opened the fracture site. And because the proximal segment was not so stable, we decided to just put one sacrilege wire to keep the fragments together. There's also the issue of using sacrilege wires and being biologic. I believe if you have the wire passers, you can easily pass a wire without damaging so much soft tissue. But there are some schools of thought that advise against this, but I found that if these fragments are not held together well, then most of the time you end up going into non-union. One fracture heals and the other one goes into non-union. Now what was this? Yes, this was a patient who was plated. And then it started healing very well. When they started bearing weight, then it started failing. What we did, I think we removed the plate, rimmed and put a big nail. And we also plated the fibula just for stability and grafted. I couldn't find the post-op X-rays. What was I trying to show here? Yeah, the fractures that are a bit distal, especially if you want to do them close, I find it easier if you plate the fibula first, then it gives you at least the length. Then you can do your rimming and nail the tibia. Although this nail was short from the word go, so we tried pushing it down. We tried pushing it down. It went down up. I think it couldn't go below this, but you want it at least lower than this. This patient had a compound fracture that was quite comminuted. I'm sorry about the X-rays, they're not the best. But what we did is we put a rush rod on the fibula and then put a spanning external fixator that took the patient to union. I couldn't get the post-op X-rays. Thank you very much. I think that's all I have. At this point, I'll invite questions, discussions, or comments for the presentation. Thank you very much.
Right. Thank you very much, Dr. Sang. Excellent presentation. There is a question from somebody, Dr. McKenna. What are the indications for fixation of the fibula? You can take that down, and then the 3 questions here. Plating versus intramedullary device for the fibula, and what biomechanical advantage does it confer?
I think for the fibula, the ones I normally plate are just the ones that are either, if they're very proximal, if there's a avulsion of the lateral collateral ligament, then I'll want to put some form of a hook plate or tension band wire just to bring back the lateral collateral ligament. That is just for stability purposes. The ones that we normally plate are the distal fractures. One, because they offer a bit more stability, especially if you have combination at your fracture site. Then 2, if they're about less than 6 centimeters from the joint line, now that is part of the ankle joint. And if you don't fix them, then you're messing with the ankle joint. So you just fix them because you want to maintain the integrity of the ankle joint, but they also confer stability to your fracture. But the other thing about nailing distal tibial fracture is that the position, I call it the exit point of your nail really matters. Because if you're using fluoroscopy and your nail goes bang to the center of this place, what you want to do is you want to error your nail just slightly lateral so that your fracture does not, your fracture line is not, you don't get displacement of your fracture. Or if you are to put a blocking screw, then you put your screw just slightly medial to the center line so that when your nail comes in, it pushes your nail slightly lateral and you avoid having displacement of your fracture, especially for the distal one fracture. I hope that answers your question.
Okay. Any other questions? Right, Dr. Kale, at what stage do you dynamize a nail, Sang?
In my practice, it depends. If it's a stable, if it's a stable like shaft fracture, then I dynamize it from the word go. I allow them to bear weight. I only lock the proximal oval hole because the nails that you normally have a proximal oval hole, they have a static and a dynamic hole. So I only lock the dynamic hole and allow them to bear weight from the word go. That is, if the fracture is stable and it won't, as in they won't lose length on bearing weight. If the fracture is unstable and I feel that if they bear weight without the static hole that they lose, they're going to, if they bear weight without the static hole, they're going to lose length. Then after 6 weeks, I assume that the fracture is sticky and I remove one of the screws. I remove the static screws and I allow them to bear weight with the dynamic hole. I think that answers your question, Dr. Kane.
Okay, further question, Dr. Sang. When do you use, what's your say on reaming versus non-reaming?
I think if normally if you want to get out, if this is a polytrauma patient, you want to nail them very fast and you want to put the smallest nail available, you want it to be easy and fast, then I'll do non-reaming nailing. But I've rarely done that. Most of the time, I want to have the biggest nail, to have a perfect fit so that this will allow them to bear weight early. Then I'll also get good stability. And what I normally do is, even if I'm reaming, I don't ream beyond the isthmus. I only ream to the isthmus and then push the nail down so that it gets also some stability distally. But I rarely do non-ream nails. But the advantages of reaming, you get a bigger nail, more stability, allow them to bear weight early. And I find most of the patients that I ream don't get complications of non-reaming.
Okay, great. Zakaria asks, have you experienced tibial non-union with fibula fixation?
Yes, I've seen that, because what most of the time, especially if there's bone loss, if you fix the fibula, it splints the fracture site and does not allow dynamization. So what happens when you come to revise, you have to refracture the fibula or remove the plate and get like a centimeter of the fibula off so that you allow dynamization of the main tibial fragments. So that one is very common, especially if there's some form of bone loss at the fracture site on the tibia. That is.
Absolutely. The fibula strut effect, huh?
Yeah.
Okay. From Zakaria Kimengich, thank you, Doc, for a good presentation you have shown us. An X-ray with fracture distal tibia fibula. Can that fracture be managed non-operatively? You look at your X-rays with the distal.
The indications, but let me see. My slide. Was it this one? This one. I think it was this one. Let me see. I don't have so many X-rays there. I think it was this one. Yes, I think it was this one. I don't have the pre, but
we can't see it here yet. Yeah, that one. Yeah, okay.
you
Maybe
can
that
see
one.
it.
Now,
Okay.
now we can see
Yeah, I
that.
think. Yeah, I think it is this one, but I don't know. I couldn't get the pre-ops, but most likely we nailed this one because of the
Yes,
displacement.
yes, yes.
And you can also see the combination of the fracture site.
Right.
I think, as I said earlier, as I said earlier, I prefer plating the fibula just to get length, because this one I did it closed. So I prefer plating the fibula just to get length, and then I do the other fracture closed. And then I ream as much as possible, so as at least to pour as you ream, the fragments are deposited at the fracture site. So it's some form of grafting. So I think that helps in healing.
Okay, so there is the opinion or literature showing that when you do reduction closed, then you
the
have
other issue
more
with non-op,
likelihood
mostly
of a union.
cast.
Right.
Yeah.
Okay. Any questions from anybody else?
Seeing somebody is asking what are the criteria for weight bearing.
The final. Yeah. What is your criteria for weight bearing? That last question.
I think all stable fractures, like 90% of the fractures that I need bear weight. Like this one, I allowed him to bear weight from the word go. This one is bearing weight already from the word go. This one is bearing weight from the word go. Because the thing is, I've put a big nail, it's stable, they're not going to, because the only fear with weight bearing is loss of length. As in, I have all these screws up and down. And if the thing is, if they bear weight, then they heal faster. They don't get, they get back to their level of function faster. And they also avoid the incidence of stiffness of the ankle joint and the knee joint. So most of them, almost 90% of the patients I nail bear weight from the word go. The following day, they're bearing weight as being allowed.
Okay, great. To summarize, there's several things that Dr. Sang has elaborated on tibial shaft fractures, with being the main concern. But he has really put an eye out, an eye opener about suprapatellar versus infrapatellar approaches, and even described a little bit of how he does suprapatellar approach. It's a very important tool in our armory. The use of blocking screws and how to put them on the concave side, excellent way of putting it, Sang. Thank you. And perhaps one small addition, you need to be mindful of the Herzog bend in the nail you're using, and be familiar with each different bend as you use your nails.
I think McKenna has one last question.
McKenna says, comment on multidirectional screws in post and proximal and distal fractures fixed with intermedullary nails.
Yeah. Now, the multi-directional screws were just created to offer stability, especially for distal 1/3 and proximal 1/3 fractures. As I told you, nearly all tibia fractures, except the ones that are periarticular, can be nailed. But there's nothing that is impossible. I've seen people using proximal tibia locking plates and putting a nail inside for a shaft fracture. But the multi-direction is just to offer stability to hold the comminuted fragment, or to create more stability, because you have a very small periarticular fragment that you need to stabilize in 3D, in both AP and lateral. So the multiple screws offer you that stability, in that they hold it stable at one point, so that you prevent movement and you get accurate reduction.
Great. Once again, thank you very much, Dr. Sang. I think we don't have any more questions. We'll hand over to Irene. Irene, are we on?
Hi, sorry. On just a few announcements. We have
Baradia is,
sorry.
I'm just saying, Baradia, your buddy is saying, sang.
Oh, okay. We have two courses coming up. Let me just share my screen. The first one is the surgical exposures and complex fracture fixation. It will be on 29th to 31st March. Currently, we just have 20 slots remaining. The next one is the basic orthopedics emergencies course will be in St. Mary's from 19th to 21st of April. And the last one, we are having the conference in June. So registration is still ongoing. You can reach to me. The number is below in case of any inquiries. Thank you for your time and see you next week.
Okay. Goodbye, everybody.